been a very fantastic morning. That'll be continually in that afternoon. This is the second Keynote address, as you know, and it's given by invitation to Sharon, Brownie. And as you can see, improving health equity and access, the power of collaborative networks. And she was asked specifically to really concentrate on collaborative networks because that is her area of expertise. She's got a CV that is kind of mind-blowing and unreadable, and has more degrees than most of us have. And haircuts are certainly. But that's what she's going to talk about today. And we welcome her to, the other thing I should say is that she's now going to be, she's been working as an adjunct at CSU for some time. She's now going to be permanent part-time with CSU here in this country. I'd like to welcome Mr. Brownie.
Thank you very much. I'm advised I need to use this because I have a naturally quiet voice. So wave up the back if you cannot hear me at any time. All right. So first of all, I'm absolutely honoured to be invited to talk. It's a little bit daunting, but it's great to be here. And I bring greetings from New Zealand. And on the lands where I live in New Zealand is the Ngāpuhi Te Aroa tribes of the north, is where I'm currently located. I've come from just finishing a role with Swinburne University in Melbourne with the Wurundjeri people, and it's great to be back here, which feels like home because I am a proud alumni of Charles Sturt's ×2. So I did a Masters in Health Service Management here and then a doctorate in this collaborative partnership-based public policy. So delighted to talk to you about that today. And I should have checked that I can then. So that's a little bit about me. I'm currently next week starting formally as a professor in the School of Medicine here. Absolutely delighted today to see some of the student work on the 5-minute presentations. Congratulations. Just finishing a 3-year contract with Swinburne. I have a major project around telehealth, digital health project with Peter McCullum, and I also work with Wintec in New Zealand. So that's just a little bit about me, so quite networked. Bit of a challenge at times to have 4 mailboxes and emails, but there we go. Okay, so today's presentation, we're going to talk about the fact that networks really unequivocally clear in my experience that research and evidence-based service improvements, they're team sports, and they require a really diverse group of people to collaborate against a common goal. And if that team is not there or the team are not on the same page, things can go a little bit screw-whiffied. The reality of why that is necessary in today's environment is about complexity and the complexity burden that seems to be increasing, both with age-related issues, burgeoning levels of chronic disease, migration, different cultural mixes, and the rural remote areas. So there's, of course, you know, like that's just a picture of me trying to draw it a little bit about what complexity is. Our situational complexity, whether we're rural and remote, the environmental factors, the socioeconomic factors, uncertainty and change, and there's plenty of that. Our medical complexity that surrounds every client and family that we interact with, and then there's the health systems complexity. So in the midst of that, we are trying to do the very best we can to deliver good care, patient-centred care to the people that we look after. And we are trying in the midst of all of that to constantly think about what is the situation, what is being done, how is it being done, why is it being done, and can we do it better? And out of that arises many projects. So today I'm going to talk to you about the fact that if you're really wanting to create changes, why do we research? If we want to create change, evidence is power. You try and rock up and convince ministers, policymakers, leaders with budgets about change, and you do not have the evidence, you don't get very far. And that you need those academic practice networks to actually be able to get the evidence. Like the work that I'm doing with telehealth at Peter Mac Hospital, I can't sit in my university ivory tower and do that project. I can do a scoping review, but I cannot actually find out what their patients think of the telehealth that's already there, what the consumers think of it, what the families think of it, how it is for the nurses there, because I have to be able to access those services and work in partnership. So today I'm going to talk to you about 4 examples, right? One from Africa, then one from New Zealand, one from Rockhampton in Queensland, and another one, some things in Africa again, and Abu Dhabi in the UAE. Things where I have worked in partnership on projects. Now, I would say that the ones in East Africa and the ones in Abu Dhabi, UAE, we ticked the box. We achieved everything we set out to achieve. It worked. The ones for Hamilton, New Zealand and Australia, they worked mostly, and then they didn't. So we'll talk about some of the success factors of what works and what doesn't. So the African example is about enhancing access to point-of-care ultrasound service. That's called POCUS, and I am, among other things, a midwife by background as well. So this is the challenge. I always start looking at a project with something called a challenge rather than a problem. Don't like the word problem. I just think it's a challenge, and how can we get around that challenge? Less than 5% of women in lower middle income countries such as Africa have access to an ultrasound in pregnancy. And that drops to less than 1.5 or even 1.3 or 0.3% other in rural and remote regions. And the lack of access to point of care ultrasound services means you get inaccurate gestational age estimates, missed pregnancy-related anomalies, missed fetal anomalies, missed detection of multiple births, and increased perinatal and infant mortality. I can remember one of the first times I went to a maternity unit in Uganda, and they had 30 women in second stage labour simultaneously at the same stage. And it was kind of like, quick, quick, you got some gloves, can you help? Right, and we delivered this young woman, and it still is in my mind. Afterwards, she just kept saying, thank you, mama, thank you, mama. I said, it's fine. And she said, I am alive. She actually expected that entering labour, there was every chance that she would not emerge alive. That was an expectation that you may die. Now, that, in my view, is unacceptable. So our challenge was how to provide POCUS in rural and remote areas. So we needed a team. As I say, it's a team sport. Who did we collate on our team? It was led by a radiologist and his team of ultrasonographers, and he happened, Dr. Vinaya Kanayak. He also was the leader of the World Radiology Association at the time. We had an obstetrician, Marlene Temmerman, who's had done a lot of work with WHO. I was the midwife. We had communities in 3 areas, 40, 100 and 400 kilometres from Nairobi. We had the telco, and you'll understand later why we need the telco. So that was like Optus, Telstra. And we had industry, who was Philips and some other providers. So that was how we started on the team. So first of all, there was the workforce challenge. Who was going to actually provide POCUS in remote areas all over Kenya? So that required task sharing, and the challenge to be sought was, how do we actually, who's out there? Well, the most common people out there were midwives. So we'll teach midwives to do the scans. Oh, says all the radiologists and ultrasonographers, is this safe? How do we know? Like we've done 3 years training, right? So the first thing was that partnership of brokering what was safe practice and how did you train and qualify a midwife sonographer. So then we developed a curriculum, and we brought some midwives in from those communities into Nairobi, into the specialist areas, and to teach them. And we had e-learning modules, basic training, advanced training, and at every stage they had challenge tests like OSCEs, and they had to pass. And it was very much pilot, and we found that to do it really, really well, you needed about 3 weeks, right? And you just taught them about scanning of women's reproductive systems and the pregnancies. They didn't need to scan chests or brains or anything else like that. So that was challenge number 1. And we ended up with really tech-savvy midwives that were able to do ultrasounds in pregnancy. So the next challenge was the technology challenge. What were we going to do? Were we going to go out there and build some centres with ultrasonography centres? And then remembering that the women would come on foot, on donkeys, on backs of bicycles, on motorbikes, on wagons, etc. So we needed to be able to take the point of care ultrasound service to where the women were, right? So what we did, and I'll show you the next little thing. This is where your telco and your industry partners worked. So on the left is a little gadget like a iPad, the scanner, and how it works is you can plug it into the USB port in a Jeep. And you can go wherever the woman is, okay? So we tested it at 3 rural clinics at Kayembu, Malindi and Embu, right? And where we needed the telco is that part of the training, we had developed a 1-page with 30 points that were tested during scanning, you know, volume of liquor, gestational age, heart valves. If there was one thing that the midwife felt was not right, we needed to upload the scans, send them down to Nairobi, ring Nairobi and say, ring, ring, and the on-call ultrasonographer and radiologist would have it, and we would keep the woman with us while we had the woman with us and do that, right? So we needed the telco, and what we found is that with the quality of images that we needed, because you have to have high quality images, we could upload the required images within and under 5 minutes, even at 400 kilometres, right? So solution in terms of how do you actually get, and what is the team that you need to get together? And quite often in our work, we think of health service teams and we think of the community, but I can't emphasise how often that technology and industry experts, and as I say, in this case, like the telco, were required components of the solution. So the outcome. The ultimate, penultimate test of whether you're doing any good is wait till the baby delivers and see if you had any missed issues, all right? So we actually were surprised. We had out of 271, we're able to trace 220 to confirm final pregnancy outcomes. And all women with twins, breech, low-lying placenta, intrauterine growth rate restriction or wrong dates were correctly identified, with the exception of a minor anomaly of 2 weeks. 2 weeks out on the date in one. So we ended up with about a 99.8% accuracy, right? Which was kind of proof in the pudding, because that's what you need to see. And then if you can detect those things, you can avoid the fact, or you've picked up that you're not going to be 400 kilometres from Nairobi and someone walks into you in full labour with a stage 4 placenta previa. You can actually bring them into a safe place for delivery beforehand. Mothers expressed high levels of satisfaction. And one of the things that was really, really very interesting was that often men in Africa are a bit dislocated from the whole family thing and the women's business. They were fascinated by the technology. And suddenly we had all these dads turning up wanting to be involved and wanting to be much more involved. And we recommended some further research about that paternal-child bonding as a relation of accessible point-of-care ultrasound service. So it was a scalable solution to provide POCUS in rural and remote areas. It's one of the more fun projects I've been involved in. This second example is around dual health workforce and primary care focus in terms of student-led and a student-assisted clinic. Now, when you have an interprofessional student-assisted clinic, it has that dual focus. Some of it's a workforce thing because you are training people and workforce to work as interprofessional teams, but you're also providing a health service, right? So that immediately raises some issues of governance. And both projects that I've been in, we have put the governance point under the health service rather than the academy. And the reason and importance for that is that the academy is not accredited as a health service provider and is not indemnified as a health service provider and is not credentialed to be having students. So that was a very good point. So there's a growing importance on this interprofessional learning and care, and those real world opportunities are scarce to actually do this. So this is one of the value of student-led clinics. And while they're burgeoning around the world, the biggest place that they're actually growing is in the US, right? And the reason for that is that it provides services to all those that don't have insurance, right? So, and there's also limited opportunities in primary healthcare for programs of care. And when I mean a program of care, so the linear model of someone with, say, diabetes, going to the doctor every 6 months for a weighing and a medication review, it does not cure a whole lot of the things like the exercise, the eating, the diet, the sticking to things. You need a program of care, and that's what these clinics can do. So I've been involved in two. I had a role for a while as the clinical director of education and training for the state of Queensland, and we had a problem, a challenge in Rockhampton. The workforce challenge was they couldn't recruit and retain allied health students, right? And they had a shortage of clinical placements. So that was the workforce challenge. The service challenge was the cyclical readmission of clients for chronic disease. The hospital were getting very irritated with the GPs because the GPs had these patients that kept turning up. They weren't doing as they're told. They didn't keep up with their blood sugar things. They were like the bad pennies that just kept turning up, sometimes 6, 7, 8 readmissions in a year, right? So it's kind of, well, what's primary care going to do about this? So the Capricornia Allied Health Partnership was a student-led clinic for chronic disease. The lead allied health person, Kerry Ann Frakes, was a podiatrist, right? And we got the referrals via the GPs, and eligible clients in terms of eligibility were those clients who the health service weren't too happy about, keep turning up and clogging up ED, etc. And when they came to the clinic, we had all allied health students. We created placements for the students in the clinics, and they would spend an hour with each patient to an hour and a half, 2 of them, doing a comprehensive assessment, listening to the whole story, and then the lead allied health, our podiatrist, would come in and check the plan, right? So it was overseen. I have to say, it was the first time some of those people had been listened to for more than a 5-minute GP visit. The first time, and it quickly turned into what was kind of a drop-in centre with charts on the wall of how many 100 kilos lost, how many miles walked, how many, and within a period of time, and there's a series of articles about this, within a period of time, some of those people had not had a hospital readmission in 2 years, right? So rapid update of referrals. So that should be actual uptake. I missed that. So there was a rapid uptake. We suddenly had lots of referrals. Referrals and enough patients was not a problem. The referrals came via the GP's health service and word of mouth, and it was a safe space for so many of those clients to come, to be heard, for their voice to be listened to feel like real persons, not the, oh, not you again. You're still not managing your diet right, you know? So it was very, very different experience, and it was a marked reduction in hospital readmissions. Those are some of the publications. I've just put them in here in case people want to look at it afterwards. Then, and afterwards, we actually also published, and I'll talk a little bit about dissemination. We made a how-to guide with all of our forms and admission forms and assessment things, just in case somebody else out there wanted to do it again, so that we could share the knowledge. So then there's Te Kotahi Oranga Health and Wellness Centre in Hamilton, New Zealand, and I've been involved as the principal investigator and lead of that project for the last 3 years. Again, the health challenge is chronic disease and aid-related challenges, high levels of falls-related hospitalisation. I was recently talking to the chief nurse for the Alfred, the biggest hospital, ED hospital in Melbourne. Their highest, the single biggest thing that's the highest cost, highest mortality, highest morbidity, and highest percentage in terms of volumes of things through the ED in Melbourne is falls in over 60s under 1 metre. Right? So it's an increasing problem. Right? We've got really high levels of type 2 diabetes, 9.1% amongst Pacific Island people and almost 10% amongst Māori people. And limited primary care programs. There's just the turn up at the doctor occasionally, get your meds. You've now gone from pre-diabetes to diabetes. The workforce challenge, again, increasing need to actually be preparing our health workforce for interprofessional practice and to deliver programs of care, particularly in health screening, falls prevention and pre-diabetes care. So again, we put together a team and those were our community partners. So we actually went out to our community partners and said to them, after first doing a feasibility, we first went out and we talked to them and said, where are your gaps? Then on the basis of that knowledge, we undertook a detailed feasibility study, reviewed the literature, did the data analysis. Interestingly enough, one other priority popped up under the data analysis. We had the highest level of head injury in the country. Then we kind of thought, why is that? What is going on? You know, is everybody beating each other up? Are they driving their cars stupidly? Are they? We had a really high percentage of Māori and Pacific people, and their kids have a passion for sport, rugby and soccer, right? So, you know, so some programs we did around mouth guards and hats and things like that. So we also did a staff survey, and then we did a whakawhiti, which is kororo, kind of like a discussion, went out and chatted with everybody again, wrote the feasibility report and said this clinic is really needed. And then we acknowledged, so the challenge then was, well, okay, we're going to do it, but who's going to pay, right? So I successfully secured a 1.5 million multi-year community impact grant from Trust Waikato, who funded the research, who funded the initial interventions and the program developments and built us a purpose-built clinic, right? And we got recurring grants for Braemar Trust for things like an HB1AC machine and the consumables. And so if you're going to run one of these clinics, if you bring your patients in and then say you need to go to the doctor to get your blood tested, so we could do it on the spot. Those are our timelines over a 3-year period. We achieved everything. Everything was delivered. Everything was on track, right? And then one of the other things is that before you start your first programs, you have to prepare for educational delivery. And what we found was that the physios would turn up and the nurses would turn up and the others would turn up and say, but the tutors would say, but our regulator requires that this is the interprofessional competency. And guess what? They're all different. They don't match. So what are you going to do then, right? So we ran a nationwide Delphi study over 13 professions and we got them to agree, right? Said, right, these are, yeah, this is, now that hasn't transferred to the regulators, but it agreed to our clinic. That's what we had, okay, right? And then we said, well, okay, how are we going to assess these? So we did a literature search around tools for faculty assessment of interprofessional competencies. What's out there? Like, why reinvent the world? What are validated tools? What's best practice? Then we looked at what are the tools for peer or self-assessment. So there's the educational component, and you see why you need a team, because there's all various different slants to this. We then looked at our 3 programs. So the 3 programs that our community told us were needed was that the number of their clients walking around. So we had a new Asian network in town with a lot of new Asian migrants and Chinese migrants, right? So we went and worked with them, but then we got an arrangement with shopping malls and we went out and we always found at least 2 or 3 people with hypertension or type 2 diabetes that had no idea. And those are quite easy things for you to implement in terms of their low risk strategies. You know, we talk again about some of those, one of the other presentations was talking about the risk of student delivery. Our falls prevention, and we actually hired an OT who was licensed to do home assessments and then a prescription which would be paid by ACC, like a handle in the shower, a ramp instead of steps. So we would individualise with a student taking out to those, and then pre-diabetes prevention and management. We partnered with our cooks and our chefs on clinical placement in the TAFE, your equivalent of TAFE. We went to the kitchen, we taught them, and then we sat around and we taught people how to eat well, rather than say, go and fix your diet. Right. We ended up with all of these good research outcomes, high client satisfaction, wonderful partner feedback, an independent evaluation that was fantastic. We're putting together a book of readings of our 13 publications. And then we talk about the continuing challenge. Both of these clinics, and I'm still in a state of grief over the Wintec one, austerity measures, change in budget. Here in Australia, if you've got allied health with a Medicare license number, that license number is not compensated in terms of if you're teaching students, you can't draw the Medicare. So it's falling between the nexus between health and education, right? As there's a problem yet to be solved, right? The models are here, the work we have done, but this is an unsolved problem. Student-led clinics fall in that nexus and revised policy and new funding models are needed. So that's where we're up to those. So there's something that worked, but it doesn't always work. Sometimes you actually have to rethink this, swallow what's happened and not be defeated and continue on. So how am I going for time? Yes, I'm all right. Okay, right. I'll go really quickly through this one and then the last one. Challenge in East Africa. I arrived there and the school had been there for 15 years, right? And they're basically the funders and were saying, you've shown us one case of excellence. How do we know where is the impact of our money after 15 years? So we did a feasibility study. We had great findings on that. Then we disseminated our evidence. And one of the things that we did is that we decided that we talked to our communities and we went out and we found 100 nurses who are alumni of the programs, and we profiled their stories, and we had enough to disseminate one chief nurses, cancer warriors, nurse teachers, youth advocates. The perception was that as soon as we upskilled them, they were all migrating out. We found that over 90% of them were still there, right? And that they were doing incredible things. Then we also did a study and that we found that those that went through the program, that the socioeconomic status of their families and for women had greatly increased. And the outcome was 5 years on, it continues to grow. The challenge in Abu Dhabi that we had, Bedouin perceptions that people who want to be nurses, they're just slaves. You know, no, we wouldn't let our family doing. We did a really complicated transnational multi-language study, and we found that that wasn't true, right? And that it's not similar. So 2 minutes I will tell you about what all this means. I did a doctoral study here in 2007 about partnership-based public policy, right? And it looked at what makes a partnership successful. And these are the findings, and these are your take-home messages today. Trust and connection, structure and systems. If you don't have those things, you're in difficulty. Trust, and we've talked about, it's been a theme throughout this whole conference, genuine focus on local solutions to local needs, real listening, building the vision together, consistent honesty, encouraging questionings, long-term commitment. And then it's no use everybody trusts each other, but you don't have a project plan, you haven't got the budget, you haven't got accountabilities, you don't have meeting minutes, and you can have all of the systems, and if people don't trust each other, then it doesn't work. Right, so those two things need to come together. There's multiple opportunities here for you to be able to be working in this kind of relationship. And today's message to you really is that there's real power in networks and there's power in evidence, right? Research and evidence-based service improvement are team sports that require diverse groups of people to collaborate towards a common goal. And success requires the teams to identify local solutions to local needs, establish trust, enact rigorous project management disciplines, and stay the distance. We are staying the distance. The story on our student-led clinics is not over, I can assure you. And ultimately, at the end, African proverb I rather liked, if you want to go fast, go alone. If you want to go far, go together.
Thank you, Sharon. That was amazing, I think. things that to us sound like just banging your head and the frustrations of these exercises. So I think you've got to be a certain type of